Health and Human Services Committee to order, and we're at 5:08, and the committee ahead of us was very courteous and out on time, maybe 5:01. We're not going to give them a hard time about that. They were very respectful, so much appreciated. We are going to let Senator Jackson, Kim, if you know, I'm sorry, 10, going to bring us to the Lord.
Let us pray. Gracious God, we give you thanks for the opportunity to gather together with each other to consider how we might care well for all of your citizens. We ask that you would give us wisdom and courage. We pray for all who work in the health and human services fields. And we pray especially for those who are sick, who are living with cancer or other diseases. We ask that they would know your comfort. Amen.
Thank you, Senator Jackson. Much appreciate that. Our first order of business actually is to appoint a subcommittee for House Bill. Where is that? House Bill 520 is the number. I had it here a second ago. It's like, hold on just a second here. I'm getting, all right, so for Senate Bill 520, we're going to do a subcommittee. It's going to be chaired by Senator Kirkpatrick, who is, she's here, but she is just stepped out. She's going to be the chairman of that, and then we're having others appointed. Are going to be Senator Setzler, Brass, Butler.
Wait, what?
Yes, we're appointing you as the esteemed rules chairman. Yes, and Hatchett, Jackson, Orrock. Now, and then Kennedy, and Strickland will be ex officio, since I understand he may be more intimately involved with that bill, if he's in agreement. Right. Yes, I love that. All righty. So as long as he doesn't ask to excuse me from the chamber, we're good. So, anyway, and we'll be meeting next Monday at our regularly scheduled HHS meeting. So that's what we'll be doing. We'll be taking testimony, and I'm sure that House bill does not need to be improved at all, but we might just have some minor improvements there that we can work on and help out like we did last time with 1013. We're looking so forward to it. Thank you. All right, so that's that. We got that done, and we're going to move to the agenda, and we have House Bill 85, House Bill 143, House Bill 203, House Bill 332, of which I am carrying for Chairman Parrish, and House Bill 440 and House Bill 343. So since I'm carrying the most important bill of the legislature, the Controlled Substances Bill, I'm going to let Chairman Parrish go first, and if this takes more than 2 minutes, I'm going to turn the mic off. So wherever you want to be, down here or the podium, whichever you're comfortable. Okay.
Mr. Chairman, members of the committee, thank you for allowing me to come visit with you just for a minute today, and I'm going to do all I can to keep you moving quickly so I won't hold you up. Just as you said, House Bill 332, this is just the annual drug update bill that we do each year. It comes to us from the Georgia Drugs and Narcotics Agency after they've consulted with GBI, and basically all we do is just update the controlled substance list so that our police officers can do a more efficient and effective job in our state. So I would certainly ask that you move this right along so that we can get that done.
Thank you, Chairman. Any questions from the committee? For those of you who are not been here before, and this is just an annual update that we do, and as Delta 8, trying to create controversy. I hear you. Okay, I'll entertain a motion now Anybody? All right, so moved from Hustetler, seconded by Senator Jackson. All those in favor say aye. All those against, like sign. Passes unanimously. Thank you, Chairman Parrish. So that comes, excuse me. So we're back on the agenda there. House Bill 85, Chair Lady Cooper, and wherever you, again, where you feel comfortable, witness or in the podium? No. Okay. All right, that's.
Before you start the timer on me, Mr. Chairman, can I at least say the 520 came out of my committee. We were not as pushed for time this year, and we have tried to do some cleaning up before it even gets over to you. There are some questions that people have, but I think it's on how they're reading the bill. So hopefully, with your heavy load of House bills, maybe we lighten the load a little bit. You ready for House Bill 85?
Ready.
Okay, this is a biomarker bill. As science continues to make progress, one of the greatest regressions I think they've made in the last few years is about biomarker testing. In the past, if you were a cancer patient, what the best the doctors would do is use whatever tried and true method they had, maybe radiology, and then just their whatever chemotherapy they thought was the best. Biomarkers allow for a patient's blood or tissue to be tested and can often tell the doctor which type of treatment is the best treatment for the kind of cancer they have. It's getting the right test to the right patient at the right time, which is in the beginning of treatment for cancer or severe autoimmune diseases. That's basically what the does. It saves time, it saves toil and patience, and it saves money because if you start a patient out on the wrong medication, infusions cost anywhere from $6,000 to $10,000 or even more, and you may lose 3 months of treating a patient only to find that it wasn't working. Their cancer is worse. And when we have biomarkers, and they're not for all cancers yet, you can short circuit that and get the right medicine to patients at the right time. And that's what this bill does.
Thank you. It's pretty straightforward. It is a blood test.
It is a
basically.
blood
It's
or tissue.
Blood or serum or whatever.
Right.
Whatever's needed.
Right.
And any questions from the committee? Do we have any, we did not put out sign-up sheets, and I apologize, but if we have anybody that wants to testify, I see a bunch of nodding their heads no. And so.
I'm ready to move. I understand this.
All right. It's pretty straightforward. Chairman Hustetler, he's on a roll. We'll take his due pass, and Chair Lady Butler is seconded. And all those in favor say aye. Aye. All those opposed, like sign. Okay, that's unanimous. Thank you.
Thank you very much to the committee. I hope no one here ever has to use the biomarkers, but if you do, I'm very glad they're there for you. Thank you.
If I remember correctly, Chair Lady Kirkpatrick.
Is carrying.
Yes, Kay is carrying that for us. And we are, and I'm carrying the first one. Got you. Okay. All right. So that's House Bill 85. And House Bill 143 is going to be a hearing only. Representative Mathis. Representative Mathis is at the podium, and this is going to be a hearing only just because the fiscal impact's unknown right now, but we're going to hear this and listen to this, and we have a similar bill that's already passed out of here that's in the House, and the podium is yours.
Thank you, Chairman Watson. Thank you, members of the committee. I bring to you House Bill 143. It's the continuous glucose monitors. Most of you know those are to check your blood sugars, whether it be high or low or at a normal rate. What we're trying to do is change it from a medical benefit on Medicaid to a pharmacy benefit. Therefore, to make it where a general practitioner can prescribe these, we don't have many endocrinologists in the state of Georgia. This will help in rural Georgia. So what we're hoping this will do is help people to monitor their blood sugars better, to give them a better quality of life. And this, you know, if you have low blood sugars, high blood sugars over a long period of time, you can have death, seizures, you can have injury from going unconscious if you have a very low blood sugar.
Mr. Representative Mathis?
Yes.
You know, this is the exact bill that we have had passed out of
Yes,
this
sir.
committee already.
Yes, sir.
Word for word. Does anybody have any questions for him? I think we gave a good, pretty explanation. Representative Setzler, your mic's yours.
I'll answer that. Mr. Chairman, appropriate time, I'd like to make a motion.
All right, what we're going to do, we're going to do a hearing only today, and we are considering
great.
you heard, and then we'll vote on it in the future, but that's what we're going to do. All righty.
Appreciate it. I like meetings like this. Thank you, sir.
Wait till we get to House Bill 520. We'll see if we can continue that. All right, so where are we? We're at House Bill 203. Representative Newton is doing double duty today, so he's got House Bill 203 and 343. So you like, which one you want, 2 or 3? Right? He wants to be in the middle. All righty, good deal. All right. The mic is yours. We're doing, let's make sure we're doing House Bill 203, and
I'll read mine.
let's give everybody a little time here to make sure we got the bill in front of us. And we're on LC 339305. No substitute. It was a perfect bill. All right, I like those. Isn't that what the esteemed chairman of the Rules Committee said down in the well? It's a perfect bill, no substitutes. Listen, we'll see if we can keep it on a roll.
Well, thank you,
All right,
Mr. Chairman,
you're
and
there.
thank you, members of the committee. I am honored to serve with you, alongside you, as we try to make life better for patients in Georgia. This is a bill, House Bill 203, 339305, LC number. It's one of those areas that we've looked at a good bit lately over the last several years, especially during COVID, but the need for more convenience and access and affordability didn't change with that. One of those areas is expanding access to telemedicine. I will tell you, it's an option for telemedicine, and I can tell you, having been on both sides of telemedicine work as an ER physician and as a patient at times, it is not for everything. It's not a perfect substitute for in-person visits by any means, but it can be an area, especially in our rural areas, but even our busy members who are in suburban and urban areas, where access and affordability and convenience can actually be much improved, a lot of times at a lower cost to the patient. House Bill 203 in particular looks to expand an option for Georgians who wear contact lenses for vision correction. Technology, as well as all of our comfort and trust with telemedicine, has increased markedly since 2015, the last time we looked at eye care in Georgia, in the Georgia Code. Over the past 2.5 years, we've worked on this bill to say, is there a way that it's safe with the right guardrails, where it could be safe for contact lens wearers to use telemedicine, or have that as an option to do telemedicine to renew their contact lenses. So we worked carefully with all the eye care professionals. That includes the optometrists who write and dispense most of these in Georgia, the ophthalmologists, who obviously are specialists also in eye care, the Medical Association, and the eye telemedicine entities as well. We kind of got all the stakeholders together, and that's why you see a bill that doesn't have substitute or changes, is because this was worked on diligently over about 1.5 years now. The telemedicine entities that can refill contact lenses use Georgia-licensed, board-certified ophthalmologists to conduct a vision and eye assessment, which is spelled out in the bill. An eye exam is something that's typically in person, but an eye assessment can be done that would allow renewal of contact lenses. That way they can refill properly performing contacts with some careful safety parameters. Some of those safety parameters are: you have to have seen someone in person in the last 24 months. You have to be between the ages of 21 and 50. Your contact lenses have to be working well for you. They do the eye assessment. You can't have any of the conditions that might make it important for you to have an in-person exam, like hypertension or diabetes or other things. So we worked on all these together and have come up with what you see today. It allows the initial prescription for any contacts, and any follow-up has to be done in person. But then after that point, if your contacts are working well, you're in those 21 to 50, you're low risk as far as no conditions that make you at risk for eye problems. So it allows a telemedicine eye assessment and renewal as long as it's been within the last 24 months. I do appreciate the work of all the eye care professionals, including the optometry groups in particular, that have worked together with the eye care telemedicine providers. And I hope you'll seriously consider this, passing this to improve access, affordability, and convenience for patients. I look forward to answering any questions.
Does the committee have any questions? Senator Brass, who may have an interest in this bill, and that I hear he may be carrying this.
I'd be honored.
Thank you, Mr. Chairman. I'm only interested in perfect bills, so this so far qualifies. Did this go through GORC?
No, it did not.
Okay. But it is my understanding that, and I think you touched on this, that everybody's in agreement. This process started more than a year ago, and they've worked in the off-season, and all parties have come together. And one of the reasons I agreed to carry it is if at any point there's changes and or attempted changes, then we'll bury the bill.
I think that's a wise course. I don't know if the chairman would like, there are some that could stand up and
You know,
voice their
again,
support.
we did not put out any things, but we're going to ask if anyone would like to testify. I see no one's willing to do that. I'm just.
You can amend his.
Would you like to
For
testify?
the optometry group, in particular.
Jeremy Collins represents the Optometry Association. We're in support of this bill.
Okay.
Chairman Collins.
Thank. So, thank you. We do have a question, though. Gotcha.
On behalf of my number one constituent, my wife would ask, and I'm just an honest question about 21 to 50. Someone in their early 50s that their contacts are performing perfectly for, why the cutoff at 50? Could it be 60? This
doesn't have to do with presbyopia, does it?
That would get involved as well. As the need for reading glasses, the vision typically can change after age 50, both directions actually, for distance as well as up close. And that's where the value of an in-person exam kind of exceeds the.
So the aging eye. And a follow-up?
The reason I asked the question was just, this is kind of the parameters in which someone can operate. I wouldn't dispute that a physician or care team wouldn't say, you know what, because of your history, you need to come back in. You're 52. We need to have you come back in and be seen. But if we cut it off at 50, are we prohibiting we're kind of prohibiting flexibility? Would there be circumstances in which a care team could decide someone that's 55 ought to be eligible for this? That's my only question.
This was a careful effort, as we've discussed, with all parties participating, and this seemed to be, with the abundance of caution, good guardrails to get common ground with everyone, and we think we found a good common ground place, and I think we had to make a cutoff at some point. If it had been 55, there's some 57-year-olds who are probably chronologically older but physiologically younger. It was just an age that seemed a relative amount of comfort. And once again, in 2015 or several years ago, we didn't know what we know now about telemedicine and eye care. We'll get more.
Any other questions? Senator Jackson, gotcha.
Thank you, Mr. Chairman. Just so the prescription that you would receive, for contacts, would it be for 24 months now, or would it be still a 12-month, and you could just have a reassessment? Is that the goal here?
That is exactly what it would allow, right?
Thank you. So, and it's my understanding for spectacles, that's a 24-month long prescription.
I apologize, but I'm not as familiar with.
Right.
With
it is.
I think that's
it
probably
is,
right.
and so the safeguard here, though, for contacts is that you have to have kind of a midway point check, just kind of a talk with your prescriber to make sure that it's good.
A minimum of an assessment, correct?
Right. And then just to be clear, is that assessment portable so can I get my contacts if the assessment is given, say you give me the assessment, can I take that assessment and then buy my contacts at 1-800-CONTACTS?
I believe you can do that if you go to an in-person exam now. you can do that. They are required
correct.
by Georgia law to give you your prescription and not require you to fill it right there. So you can do that part now. You didn't need, this just allows the telemedicine where you don't even have to go schedule time off work, schedule an appointment and go in person. You can just do it through telemedicine.
So they're going to give me a new prescription. It's
Well,
going to sound.
It may be a refill of your prescription, or it may be a,
refill.
right.
Or it may be a change, and you can get that prescription, take that prescription wherever you want to.
That's what I wanted to make. But really, it's a refill. I'm trying to figure out how we have safeguards to make sure that I'm not just getting reassessments every time. So it's actually you get a one refill on the original examination. Is that correct?
So we got someone to clarify this. Policer?
That's-
Hey, Edens Davis, 1-800-CONTACTS, representing them, contract lobbyist for them. So this would be, our company and probably the leader in this space would only do it for this existing prescription. There's no change in prescriptions. That's part of that. If you needed to change anything, something wasn't working with you, you would be doing that in person with a comprehensive eye exam that's explained in this bill, in this code section.
So then to be clear, the prescription itself is good for 2 years.
1 year prescription, and then you could do up to 2 online renewals, and then you would have to go back in person.
What's the safeguards to keep me from just always doing an assessment? That's my question.
Oh,
That's my only question.
You have to verify, the provider would have to verify that you've had an in-person exam within the last 24 months. That's in the bill.
But you may want to keep his number, that 1-800 number there.
I think you can get your.
I got you.
I think I might know that one.
Okay, I got you. All right, Senator Rock.
Thank you so much. This seems to be a great course that we're pursuing here. I'm not familiar with other states or how widespread this is. Doctor, you may have some idea of that.
I believe we're one of, is it 3 states that don't allow this now?
Yes.
Oh,
Yes, we're only
One of 3 that do not allow. This
Only
has
one of
not
3 that do
been,
not allow it.
this concept has not been new. Senator Brass worked on this 4 or 5 years ago, something like that. And we're good. All right,
So
so
thank you for that.
any other questions from the committee?
I know it.
Ahead of his time. All righty.
man of vision.
I'll be happy to entertain, before we get too deep here, happy to entertain a due pass.
I move we pass.
203.
House Bill 203 with no substitute, LC 339305.
Second.
Second by Senator Orrock. All those in favor say aye. Aye. All those opposed, like sign. Thank you.
I like that. Kill it if anything changes. Let me look at this code section.
It's a balance there, and Skin's trying to, they're trying to keep it from getting it changed. It's a back and forth.
Mr. Chairman, I appreciate your support. I'm here to help in as many ways as I can. The hearing aid, was yours the hearing? I saw that.
I'm going to have you step back, and then we're going to do House Bill 440, Representative Stoner.
Thank you, Mr. Chairman.
The floor is yours. We're on House Bill 440.
Right. Should be LC 49LL53 and
No
this
S,
is-
okay.
no,
you're
it's
up.
no substitute on this one either. Thank you, Mr. Chairman. Thank you, members of the committee. Good to be back here in the Senate, though I'm visiting over from the House and everything. What this bill does is HB 440 is what we call ready-to-use glucagon rescue therapies for schools. So if you're familiar with our public schools and private schools, we currently allow schools to stock things like EpiPens, albuterol, and Narcan for emergency purposes. And what this is, and I actually have an example of this, and by the way, this is my wife's glucagon kit. She's actually here. My number one constituent's here also. So she doesn't stay far away from this, so that's why I have to give this back to her right after I get done. So the point of this is these are for type 1 diabetic children who are currently in our schools, and every child is prescribed, as every adult any type 1 is prescribed this glucagon kit. And what we're talking about is when someone has a hyperglycemic episode, in other words, where your glucose level drops dramatically, and let's say orange juice and cookies isn't solving the problem. Hopefully the child has this with them at school, and either the nurse or the trained personnel, because we have a student diabetes management program requirement for every type 1 diabetic student in schools, is able to open this up and give this to the child. Because if you're in that state, you're not, let's say, necessarily coherent at the time. So the point of that is, but we all know this, children lose things, and they do lose their prescription medication. So this is not requiring schools, but it's authorizing our schools to be able to legally carry what you would call either unregistered or unprescribed glucagon pens. That's a term you'll hear in glucagon kits. Currently, obviously, they're not allowed to do that, but this would allow them to be able to do that. Also, for the pharmacies to also legally to prescribe these, to fill these prescriptions, and for doctors and those who can prescribe to do that. So that's what this bill does. It covers all that. And again, this is not mandating the schools. This is just authorizing the schools to do such. Just very quickly, Illinois has done this, and Ohio has done this. West Virginia is currently considering it. And I think it's just something that someone asked me the other day why, they were shocked that we hadn't done this already. And it's just like we know a lot of times down here, it's just one of those things that for whatever reason we never got around to. So that's what this bill does. It's very straightforward. Has the support of the American Diabetes Association, the Georgia School Superintendents Association, the Georgia Association of School Nurses, Georgia Association of Educators, and the Professional Association of Georgia Educators. I think I got everybody. And happy to entertain any questions.
Any questions from the committee?
Thank you.
Okay. Got it. No questions? Motion to pass, seconded. All those in favor say aye. Aye. All those opposed, like sign. All right. Representative Stoner, anybody carrying that for you?
Yes, since it's a perfect bill, apparently, I asked Senator Brass to carry that for me.
Oh, all righty. All right.
Chairman Brass, that is correct.
Yes.
Chairman Brass.
The distinguished.
Yes, distinguished Chairman
Distinguished. He has corrected me. It's not powerful, it's distinguished. So next year he'll be powerful, that's it. Or the year after?
Well, Mr. Chairman, what I learned was I'm distinguished and powerful to you senators until all your bills pass, and now I'm nothing, so. But now I'm distinguished and powerful to all the House members.
Well, I was about to say.
There we go. I got you. All right. Listen, got the ground rules. Okay.
Thank y'all very much.
Okay. Well played. All righty. So we've done 1, 2, 3, 4, 5. We're doing number 6, and we're at House Bill 343. Representative Newton's back up. LC 339467S. This one is not perfect, and we're going to do hearing only here after discussion and conversation. We're going to do a hearing only, and so if we have anybody who wants to testify, we're happy to hear that, and we're on House Bill 343.
Thank you, Mr. Chairman, members of the committee. I do come back, just like we did with iCare. We try to make small improvements over time. I think House Bill 343 will give us the opportunity to working together where a certain group of people who have conditions, health conditions that can't be solved with surgery, no matter, or medical procedure that might be expensive. If you recall, those typically have a list price from a hospital or surgery center and then a big contractual discount, and the patient pays a portion of that contracted amount, that lower amount. That will, for the first time, bring that some of that same benefit to patients whose conditions require fairly expensive medications. Some of these are life-altering medications. Some of them are life-saving medications. Little background right now, what this legislation will do is it'll help save patients the out-of-pocket cost on their needed prescriptions, and it does this by calculating their out-of-pocket costs, which is determined at the pharmacy. It'll calculate it not on the list price of the medication, but on a portion of the discounted price. That's usually a post-discount or a post-rebate price rather than that higher list price. There were some concerns expressed in the perfecting of this legislation over the last couple of years to look at what could be the impact on premiums expenses. I can tell you we've done several things to try to address that. Number one, this doesn't apply at all to federally regulated ERISA plans or things like state health benefits. Those plans are already large enough to where they can really essentially demand, like SHBP does, that there be some transparency through a third-party audit system and that the rebates can be utilized either to lower the patient's cost or to lower the premium cost or some of both. What this bill will do is it's going to allow a rebate, for example, maybe $1,000 a month medication, but the rebate may be $500. And so the true price of the medicine, you could argue, is $500. Unfortunately, in the current system, if you go to pay 20% for this needed medicine for you or your family member or patient, you have to pay 20% of the $1,000 until you reach your deductible, usually. What this bill would allow, it wouldn't take it all the way down to the true price, which is what many would like, is just like you do with a surgical procedure or anything, hospitalization or anything. It would just take it down 50% of that rebate. The other 50% could be retained by the PBM or the insurer to keep premiums down, to handle administrative expenses or whatever else the PBM felt was important. So that was an effort to try to make sure we minimized the impact of any bill on potential prescription prices. I will tell you there's a large state that has done a 48-page fiscal note on a similar plan, passing 90% through to the patients in California, and indeed there is a premium impact. The premium impact was calculated to be 0.1%. Just for purposes, 0.1% on a state health benefit, $980 a month cost is like 98 cents a month. So there is a premium impact. It's just minimal. But once again, out of an abundance of caution, we didn't go with 90% benefit to the patient. These patients have medical conditions that are serious. Sometimes it can be cancer, sometimes multiple sclerosis, other illnesses to which medications are actually incredibly life-saving and life-changing. So number one, we left out ERISA plans. Number two, we lowered the benefit pass-through to just 50% so that the PBM can retain the other 50% to lower premiums. And we expect it to have less of an impact than the 1/10 of 1%, but it could easily be 50 cents to $1.50. Could be in the range. And once again, out of even more caution, we put in there a transparency piece at the end of the year where the Department of Insurance, and once again, these are state-regulated plans, not federally regulated plans, not Medicaid, not SHBP, but it would require some reporting to where the Department of Insurance would be able to carefully evaluate whether there might be a potential future impact on premiums, and that way this body could act quickly as long as we have the information. Once again, there's a lot of protections you'll notice in the bill to make sure that confidential information is kept confidential. Nothing about the actual price of a particular blood thinner or something like that. You wouldn't know the price and the rebate on that with the reporting, but in some aggregate amounts to where the Department of Insurance would have information to make sure they're able to assess for any potential premium impact. So we know there'll be some premium impact. We think it'll be minimal. If you could hear from, we heard in several committee meetings previously, if you can hear from the advocates who represent many of these conditions that have life-changing medications available, but the difficulty in supporting and affording them, you would see how much of a difference this can make in patients' lives. In the same way we get joy out of fixing a broken arm or a laceration or reassuring someone who's had a head injury in my fields. Pharmaceutical benefits can be incredibly, they can be costly, but they can also be incredibly life-changing. And I hope you'll work with me and we'll be able to go to those patients and let them know that we're here sticking up for them here. Once again, we're making small but tangible changes and improvements in their lives, and once again, I'm honored to work with you on doing that, and I hope we can get to a point where this committee would support that when the time is appropriate, Mr. Chairman.
Thank you, Representative Newton. Do you have any questions at all? This is a hearing only. Let's do questions. If anybody wants to testify, we can do that too. No questions? Anybody want to testify? Yes, sir.
Are any other states doing this or trying to do this, or?
West Virginia's tried, California's looked at it, and that's the 48-page fiscal note. It is often fought very vigorously, and frankly, PBMs bring a lot of value. They, in the same way a contractual discount from the list price for a hospitalization or a surgery center is a great benefit that we get by having either an Anthem or United or Humana card. We enjoy that benefit, and that's something that insurance companies work hard to do. PBMs work hard to get discounts. This bill just allows a portion of that discount, a large portion to stay with the PBM, where it can be used for whatever admin costs that are involved in negotiating those discounts, or it can be. Stay with them to make money. Well, they are very profitable, but we're not typically trying to beat up on somebody just because they have a business model that's profitable. But we do want to look after patients, because that's who actually sends us here. And so when push comes to shove, I think we've worked and been able to find a common ground, is the term I would use, to where that the PBMs can get reimbursed for their work and the value the real value they bring, but at the same time, we can have the patients have the benefit of some of those discounts.
Could I have a follow-up, Mr. Chairman?
Yes. Once you follow up, and then Senator Lucas.
You said West Virginia and California were looking at it?
West Virginia passed a bill similar.
Okay.
And
in California?
California's looked at it, Assembly Bill 993, which is once again, it's the
Did they pass
the fiscal note. It did not, no.
Why did they not pass it?
Probably I shouldn't speculate.
Okay.
Sorry.
All right, Senator Lucas.
Doc, I think you're doing the right thing. I've been a diabetic 30 years. I got a monitor. They sent it in. I ended up getting a bill for $800 because the PBM wouldn't approve it. I threatened to sue them, and then they approved it. And I'm serious.
They didn't know who they were dealing with.
Well, but you have new technology on all of the things that have evolved around people being sick. Right now, my diabetic doctor prescribed Mounjaro, a once a week shot. She gave me a sample. I lost 10 pounds within the month. A1C went down from 11.2 to 8.1, and the PBM won't approve it. So now I got to threaten to sue them again. I mean, it doesn't make any sense. If people stay healthy, then you don't have to worry about them going to the emergency room, getting a higher cost treatment.
That is an excellent point, that while your pharmaceutical costs might go up a little bit under this bill because of the sharing of the rebate, it is possible, until someone tries it completely, especially a larger state, it's difficult to know if those complication costs you mentioned, emergency department visit, hospitalization, not to mention the personal cost of those, but even just the financial cost to the state or to the other insured. It could very well be that the premiums go down once people don't cut their medicines in half or skip every other day, or all the different things. I know the chairman's probably seen people try to make patient medicines last.
I mean, Senator Lucas gives a good example. The GLP-1s are a major issue right now. But it's a complicated story having to do. I mean, we even rope in Kim Kardashian and Elon Musk into that scenario of weight loss. And though I'm not, as I've said before, not a big Kim Kardashian fan, she did bring light to a drug that is very useful and yet very hard to get approved. And it just doesn't make sense. I mean, it's a money issue. I get it. They're paying the bill. So, Senator Sessman.
Good answer.
To Chairman, is any state done a rate study that's laid out a whole schedule of cost that's just publicly? I mean, I was under the understanding there's a consultancy, and I heard the term recently. It was a private entity, SSR. They're a consultancy that pegs prices on drugs comparatively across systems. Have we as a state looked at what we're paying, what other states are paying, what other big players are paying?
Not that I know of, that we've looked at that. State Health Benefits certainly does a great job, in my opinion, of overseeing the 620,000 covered lives there. And they look carefully at these numbers. As a matter of fact, $1 billion was the approximation of the spend for the 620,000 of the covered lives. And there were $350 million in rebates on that $1 billion. That was 2 years ago. There is big money in rebates. I'm not sure if that might have a reason why these bills have not gone any further than they have. But that's one of the reasons we are taking a cautious approach with only 50% of the pass-through. I'm not sure of any study.
DCH has done some of that, and there are formularies and so forth that are being, that have been constructed relating to Medicaid, and will go with the State Health Benefit Plan too.
Can we have access, as legislators, do we have access to see that, just to go down a list of, I mean, how many
Yeah,
drugs are
I'm
on?
not sure that's, I mean, I think that's a matter of public record. Now, is it in preliminary stages? It may be. So they would be able to answer that, but that's sort of another issue than this particular bill, even though it may have to do with rebates. Did you have a question, or, okay. Senator Huffstetler?
Just going to point out that Arkansas passed this yesterday at 100%, House Bill 343. When Dr. Newton brings bills over, I study up on these things, so I just want,
Thank you. Okay. All
or
right.
maybe I phone a friend, I don't know.
Both can be helpful.
Any other questions? This is hearing only, so if anybody would like to testify, happy to testify. If not,
Mr. Chairman,
yes,
just
yeah.
Just ask a point of clarification. Will there be an opportunity for further testimony at a later time?
We will.
Okay.
Okay, when you're prepared. Gotcha.
Yes, sir.
Okay. Anybody else? All righty, then I will take a motion to adjourn. How about that? All those in favor, say aye. All right, ayes clearly have it. All right, meeting adjourned.